fortunate. We have 3 doctors scheduled. 2 of them are here. And if you remember the old Meatloaf song, 2 out of 3 ain't bad, we will go ahead and get started with our program tonight because we want to respect our physicians who are here and going to give us information. We want to cover tonight urology, radiation, and research. And our radiation and research physicians are here. I'd like to introduce those folks to you tonight. First of all, Tanuja Bhandari is our radiation physician. She has a Bachelor of Science in Biology from UC Irvine. She got her medical degree from the American University in Coral Gables, Florida. Did her postgraduate training in internal medicines at Johns Hopkins University in Baltimore. Did her residency at Drexel University in Philadelphia and joined the Radiation Associates Medical Group in 2007. She practices at Vantage Oncology Centers in Riverside and San Bernardino. She has been a huge supporter of our foundation, has been a speaker many times at both prostate cancer and our Esperanza para Mujeres group. So let's please welcome Dr. Tanuja. We also have as our research physician tonight, Dr. Tanya Dorff. She got her BS in biology from the University of Houston, her medical degree from UCLA, did her residency at Mount Sinai Hospital in New York, had a fellowship in hematology and medical oncology at the USC Medical Center, spent 3 years at the Angeles Clinic and researched GU Oncology in Los Angeles, and for the past 1.5 years has been at the USC Keck School of Medicine as a teacher and researcher, and also as a private practice at the Norris Comprehensive Cancer Center. Dr. Tanya Dorff, please welcome her this evening. So doctors, what we'd like you to do is go ahead and take the microphone and in your respective fields of expertise, give us an overview as to what is new, what is maybe coming in the future in terms of radiology and research, and then hopefully Dr. Haishaw will then be here. We can introduce him and he can speak to urology. So Dr. Bhandari, would you start us off, please?
You all here in the back? Yeah, okay. There's a nice handout that Joanne Gosling and myself put together for you. It kind of goes through a little bit about prostate, what is the prostate cancer, and radiation therapy. In radiation therapy, the technology keeps changing, as you know, or may have read about. Constantly getting new treatments, new modalities, new computers, fancy toys. So nowadays we're doing something called image-guided radiation therapy. I'm probably about 3/4 of the page down if you're just kind of following with me. What we do is we can, while the patient's being treated, we can kind of in real time track how the organs and how the cancer moves, and we can adapt our radiation therapy and deliver radiation therapies so we can minimize the toxicity and treat the cancer while it's sparing the normal tissue. So that's something that's kind of new and exciting in our field. Some of you may have heard of fiducial placement, where we use a tracking system where we place fiducials into the prostate, and with that we can track the movement of the prostate as we treat with radiation or X-ray therapy. Some of you may have had intensive modulation therapy with IMRT, which is now the standard of care for prostate cancer treatment. And then on the back side, I go a little bit about the radiotherapy, where we actually place radioactive seeds into the prostate gland under ultrasound and fluoroscopic guidance. So here's some new and exciting treatment modalities for radiation therapy. If you have any questions at the end, I guess we can go through answer questions. Both my partners, Dr. Hako, she's from Loma Linda, has a lot of experience with proton therapy. She joined our practice and she also treats prostate cancer. So full information, it's a great handout. I hope it helps. I hope we can answer some questions for you.
So my handout is not nearly as nice, but I do hope that it will help you if we end up talking about some of the new exciting therapies, just to have the names there and a little bit about what they do, because the names can get a little bit overwhelming. So in addition to doing research, I do treat patients, and for the first time in many years, we have new drugs that we can treat patients with. So I've just highlighted a few of those for you in the handout. The first one being Provenge, also known as Sipuleucel-T or SIP-T, if you're really cool. And we are using this now. It's FDA approved. It is a available. Most insurances do pay for it. Sometimes there's a copay, which can be pricey, but we have treated a number of patients, and it's a nice option to have in our pocket for those of you whose prostate cancer has already left the prostate and is in other organs. The second drug, if you go to this backside of the first page, cabazitaxel, the brand name is Tanya. So that's a new chemo drug that we have for patients who have already gone through Taxotere or docetaxel chemotherapy. It's a tough drug. We've been nervous about some of the very severe side effects that were reported when they first announced the success of the drug. But I have to say, now that I've been using it for a few months, it's actually much better tolerated than I anticipated. So I have seen some men benefit from it, and I'm certainly not seeing anyone get hospitalized or have severe complications from it. So much better than I expected. And again, both of these drugs have been shown to provide a survival advantage for men with advanced prostate cancer that's gone outside the prostate. And we're really happy to have a couple new tools. It's been a long time. The third and fourth drugs are not quite available yet. Abiraterone, the third drug, is going to be a new hormone pill. It's going to be a blockbuster drug. And just about a month ago at the European Society of Medical Oncology in Milan, they presented the first peek at the data showing a survival advantage for their drug on average of about 4 months, which doesn't sound like a lot, but that means some men get 2 years and some men get nothing, and there's everything in between. But considering that it's a pill, very few side effects, it's a fantastic breakthrough. So it's not going to be commercially available. Well, they're submitting to FDA in December, which means FDA has probably till about June to approve it. But in the meantime, they are opening a compassionate access protocol, and we are going to have that available. So, and there will probably be centers closer to you as well that will open it, because it's a great drug. We want people to have access to it while FDA is working through their process. And that fourth drug, denosumab, is approved now for osteoporosis. So it's a new bone strengthener. Right now, you may have heard us talk about Zometa. We use that to help you guys stay strong, prevent fractures, reduce bone pain for prostate cancer and the spread of the bone. Denosumab may be more effective, depending how you look at the data. The two advantages I see are that it's a sub-Q shot instead of an IV infusion. Kind of nice. And then that it doesn't irritate the kidneys, which can be an issue with this Zometa. So those are 4 of the new drugs. There's lots more, but I just wanted to highlight those, and then hopefully if there aren't questions, we get to talk about those more. Thank you.
All right. Now, that's a brief overview, and that's the way we planned it. Again, this is your night, and you as a group are always great about asking questions and gaining information. So we have the 2 physicians here dealing with radiology and with research. So what questions might we have for the physicians tonight? Lenny?
My question on the Provenge, right now I'm taking Lupron, and would that be better to take instead of the Lupron? Because the Lupron side effects for me are just horrendous. So
yeah, so the question is Provenge going to be something that is better than Lupron? And the answer is no, unfortunately. It's an immune therapy. Unlike Lupron, which works for about 95% of men and works for an average of 2 years, and really I've seen men go 10 years responding to Lupron, the Provenge was really only tested in men who have already started to progress in spite of the Lupron. So the survival benefits were seen in that kind of later population. Now there was a study trying to use it earlier in men where PSA has come back after surgery or radiation,
right,
and they either got a shot of Lupron or they got a shot of Lupron and they got the Provenge treatment, and it looked like there might be benefit. We have to wait a really long time to get that answer because you guys live a long time and you do really great. So we won't know how big an impact it makes. But we are interested in using it earlier. I think partnering with the immune system in conjunction with drugs like Lupron is going to be a better success story. So we're going to be opening a trial where we give the Provenge before prostate surgery. And there's a lot of excitement about using immune therapy earlier in the disease.
Can you take the Provenge with the Lupron?
Right now, the Medicare reimbursement rules, which set the standard for most insurance companies, require that you have PSA that's rising in spite of a testosterone less than 50 or in spite of being on Lupron.
Okay.
You also have to have visible spots on a scan, there's bones or.
Right, if it's outside the prostate, which,
Yeah.
which it is with me, so.
So you have to check those boxes. And it's
Okay.
an expensive treatment. It's $93,000 is supposed to be the package deal.
Oh, I'll just write a check right now.
I have a question for both doctors. Dr. Dorff first. The average 4 months for Provenge for many of the new drugs is measured in months, not years. But as you indicated, there's a range. Have you a feel for what the longest range was with Provenge?
Well, I think better than talking about the average, which doesn't really explain what happens to an individual, is to look at the survival curves, which is why I put them on here for you. So it's the top graph on the second page, the D9901. So if you look at who's alive at 3 years, 3 times as many men who got the Provenge are alive at 3 years. So you triple your odds of being alive at 3 years is maybe a more compelling way to look at it.
I didn't see that handout if there are.
Yeah, I only made a few, so, but I'll leave one with Jimmy maybe.
And then for Dr. Bhandari, what is radiosurgery and how does it differ either from proton beam or IMRT?
That's a good question.
Okay, very good.
So
Thank you
the
very
question
much.
is what is radiosurgery? And what it is usually when we give radiation, we give you a small treatment every day for a number of weeks, usually around 5 to 8 weeks. Okay, and that's called standard fractionation or standard treatment. When you do radiosurgery, we give you a large dose in a smaller amount of time. So a big dose of radiation is what radiosurgery is.
Same technique, just more concentrated dosage.
The techniques are a little bit more advanced, meaning that we use a different machine to do that because we have to deliver higher doses of radiation, but we give it over a smaller time.
Any tie with tomotherapy in the sense that it's real-time
Yeah, and
imaging of the
actually
prostate?
What they do when they deliver such a high dose of radiation, they do sometimes called 4D or gating or chemotherapies. We have to make sure that the patient is in the accurate position in real time. So that's a modality that we use to deliver such a high dose of radiation.
Thank you.
Bye-bye, nice to meet you guys.
If she likes.